you guys for coming. Did everyone get a drink and a bite to eat? You're welcome to amble around and grab some more to drink or eat while we're chatting. But I just really appreciate all the familiar faces. Thank you all for coming and making an effort after riding your horse today to get through traffic and get to us. So we appreciate that. I just wanted to say a couple quick thank yous. The first would be thank you to Fortune Ridge Farm for hosting us today. Thank you all. They can tell you more about the beautiful facility here and the houses for sale across the street if you'd like to learn a bit more. Thank you to Ella for putting all of this together and organizing the food, the drink, and all of the speakers today. And we are obviously Grand Prix Equine. We're based in Newtown area, but we do have practices up in Granby, Connecticut, Madison, Connecticut, where Dr. Luvie here lives. I live down in Bedford, New York, and we are continuing to expand every year. So we're continuing to grow, and we wanted to put on this meeting today to invite everyone to learn a bit more about what we offer and a bit more about a very, very common theme that we hear and get a lot of questions about. So I also wanted to thank a couple sponsors. We had Zoetis help with our food. We had Covetrus help with the beautiful flowers. We had Dover sponsor a gift basket with a $150 gift certificate. So thank you, Dover. And who else is there, Ella? And Platinum Performance also donated a free bucket of platinum. Throughout the two talks today, we're going to be having some question and answer. So if you do answer a question right or wrong, then you will get another raffle ticket. And then at the end, Mark is going to pull the tickets and say who won the raffle item. So thank you guys again for participating, and Sandy will be your girl to get extra tickets. Hopefully everyone got one ticket when they came in. Good, you're starting with one. And then without further ado, I wanted to introduce Dr. Abell. 2 years ago now? Got your chiropractic?
Yeah, 2020.
In 2020, she got her chiropractic certification and has added on that service to all of our clients. It's been fantastic, great feedback. And she knows a lot about axial skeleton through continuing education as well. And then the way that we connect with our horses back is via our saddle, right? So thank God that Karen is here to speak more about what she knows so intimately in the saddle fit process and helping our horses stay comfortable and continuing to perform. All right, so without further ado, thank you, Dr. Abell.
Just a little bit about me. I graduated from the Virginia Maryland College of Veterinary Medicine in 2017. That's at Virginia Tech. So had some fun time there. This is me and my horse. So after vet school, I did my internship at Blue Ridge Equine Clinic in Virginia. Joined Grand Prix Equine in 2018. Later into 2018, I attended the ISELP, which is the International Society of Equine Locomotor Pathology, their module on the neck and the back. And then in 2019, I did their 3-day module on the pelvis. In 2020, I went to Options for Animals School of Animal Chiropractic and was certified by the International Veterinary Chiropractic Association through that program. And that's my little family up there, and my 5-month-old who's at home. And yes, my thoroughbred, my other very large baby, whose back is the background of these slides. So I'm from my pre-purchase. Bought him with Kissing Spine. So we can talk a little bit more about that, of course.
Is that why you got into this?
I actually got him afterwards.
Okay.
Yeah. So, but I grew up riding a lot of thoroughbreds, and back pain and kissing spine is so common with them. So definitely sparked some interest there. Always had an interest to pursue chiropractic. But yeah, definitely seeing his back didn't scare me, I guess. But with also, I got a second opinion from Dr. Bass, too. Because, we can't be objective with our own horses. So with back pain, we've developed a lot of new understanding. So there's this general old thought process that back pain is only related to saddle fits. If you have a properly fitting saddle, you know, your horse's back is fine. Or that if you do have a sore back, it's always going to be coming from a hind limb lameness. So if you fix the hind limb lameness, the back pain is going to go away. And while that is sometimes the case, it's not always the case. And then that, you know, kissing spine is the only cause of back pain. So if your horse has clean x-rays and doesn't have kissing spine, then, you know, it can't be back pain. When in reality, we now understand that that back pain can be a primary source of poor performance and pain in our horses, and there's a few different pathological processes that can cause back pain. It's not just kissing spine. So some signs of back pain, I'm sure that we've all experienced this to some degree. This is a long list. It's very, you could say that there are a lot of other conditions that can pop up like this, which is why can be difficult to pinpoint from a clinical historical concept. But the signs are vague, very subjective, but we find just general poor performance, reluctant stiffness. A lot of people say bucking, rearing. At one point I believed that particularly bucking, in my mind, that requires a lot of effort from the back. So I just thought horses with really severe back pain, there's no way they're going to be bucking. Like, that takes a lot of effort for them to pick up their hind legs and kick up like that. Which I think for severe cases, yes, but for mild causes of back pain, I think horses are willing to exert themselves to a little bit in order to communicate effectively that they're uncomfortable. More extreme degree of reluctance is what you could kind of categorize that as. And asymmetrical through turns, a lot of horses, you know, will turn better one way than the other, or, you know, stay round or balanced and more so in one direction than another. Lack of propulsion, specifically in the hind legs, is very common finding. And sensitivity to the saddle, or when we're tacking up, or when the rider gets on, that reluctance or hesitation as soon as that happens is a common finding. And then less common but more severe sign would be something like muscle atrophy, particularly if there's an asymmetrical degree of muscle atrophy, but or a segmental area of muscle atrophy rather than throughout the whole back. And of course, it can present like other conditions, like I said initially. When we have something like this, and the conditions floating around in my mind are, is it gastric ulcers, is it back pain, or in this area, Lyme disease can present similar to this. So it can be kind of confusing, and it can kind of take some of the diagnostic steps that I'm going to talk about next to really sort out, is the back really painful or not. So for our diagnostics for back pain, with the signs that I just went over, they're vague, of course, like we discussed, and none of the diagnostics are perfect. So with that combination, it can be a difficult diagnosis, but we do our best. And the mainstays of the diagnostics that we have in our arsenal are our examination, which is always going to be the most important step. I get so many calls and requests for, I want back x-rays for my horse. And I hesitate and I say, we really need to start with an exam. And I'll go into that a little bit more, but a picture is worth 1,000 words, but it does not tell the whole story. So we need to start with an exam, diagnostic analgesia, or what we call nerve blocking. There's some pros and cons to that, some successes and less so, specifically with blocking backs. We'll talk about that. And then diagnostic imaging, which is our mainstay of diagnosis for figuring out what is causing the back pain. So for the back exam, we'll start with a physical exam, and that's a combination when it comes to the back, static palpation and mobilization of the spine. The horses have thick musculature. It makes palpation difficult and subjective with our interpretation. We get false negatives and false positives. So a horse can have a painful back, but a nice thick degree of musculature. We can palpate that all day and they're not going to flinch. Versus some horses are just touchy and they're can have no sign of no true pain, but you poke along their back and they're going to flinch, and it's confusing. But it's an important part of the picture. And then in terms of mobilization, horses' spines are very rigid compared to, you know, us or dogs. Compared to other species, horses are meant to be very strong and stable through their backs. So that makes for mobilization of the spine from a examination point just a little bit more difficult to identify, you know, this region is lacking a lot of mobility. So in terms of nerve blocking, most people tend to be more familiar with nerve blocking in the limbs. Is anybody not familiar with diagnostic nerve blocking for like the lower limbs or anything like that? Okay, so we understand that we can put some numbing agent to a region and then assess the horse's response after that and determine whether or not they are going better. And normally that's when we have a lameness that we're identifying, so basically like a head bob or a limb lameness that we're identifying. When it comes to a back, the signs that we're seeing are so vague, so then the response with a block tends to be very subjective to interpretation. Usually we're asking more of the rider of how the horse is going, more so than the vet being the one to assess the response. And then in terms of the risk, you know, sticking a needle deep, very close to the spine, we're close to some really important nerves that branch very close to the spine itself. There's a little bit more risk involved to the horse than say a distal limb nerve block. And then also for the vet, because we can't, you know, if you've ever seen us do like a foot block or something, we're using a really little needle and it's really short. But if we're trying to get a good block of the back, we have to use a larger needle that's a little longer, and not every horse is going to be very tolerant of that without sedation, because the goal would be to be able to put a saddleback on them and ride them afterwards to see if they're better. So we can't sedate them for that, as it sounds like you guys will all you know, understand based on your experience. So a little bit more risk involved for us, a little bit more risk involved for the horse, particularly if we're talking about trying to block a neck or a sacroiliac joint, because again, it's just more risk to get near the spine versus kissing spine. There's a little bit more flexibility with trying to block those. And diagnostic imaging, I'm trying to decide if this is a good spot for a question. Can anybody tell me what these images, which diagnostic imaging technique is being shown here?
Thermography?
Down here?
Yeah.
No.
No.
Sorry. Good guess though.
Who said
Anyone
that?
else? Yes?
Yes.
To show the inflammation with the heat
Did you say that?
coming out.
You just said it was wrong.
So that would be thermography.
Yeah, well, it's good.
So which modality, which diagnostic imaging modality is being showed in these two images? Who said it? Nuclear scintigraphy. Yes, she's right.
Woo-hoo.
So the diagnostic imaging options that we have are radiography, which is, you know, our x-rays, very good for kissing spine. Ultrasonography, which is we can assess kissing spine and also the soft tissue, the neck as well. But we'll talk more about ultrasonography when it comes to osteoarthritis of the spine. And then nuclear scintigraphy, also known as bone scan, which takes up hot spots or areas of increased metabolic activity, particularly in the bone. And then thermography is not something that we do, and it's very subjective, but I found this image to be really interesting of a fractured right ilium in a horse. And then specifically for the neck, we have options like myelography, CT, and MRI. I felt like we should include these. We're not really talking about the neck today, but you know, it's all connected in the spine. But it's really unfortunate that there's just no machine big enough to fit a horse's spine through an MRI or a CT. So those options exist more for our small animal patients, but not for the horses, unfortunately. So with these diagnostics, the specific diagnoses that we might find and associate with back pain will be dorsal spinous process impingement, or what we call kissing spine, and osteoarthritis of the intervertebral joints, also known as the facet joints, the actual synovial joints that are between the vertebrae. that exist on either side between each vertebrae along the whole column. And then the ligament that runs along the top of the spine is called the supraspinous ligament, and that can get inflammation or damage, and that's what we call supraspinous ligament desmopathy. We can have curvatures to the spine, so kyphosis, which would be roached back, which we've all seen a horse like that, or lordosis, which is a sway back, or scoliosis, which is a lateral curvature of the spine. A little bit less common, something that I see more in chiropractic, but still there. And then spondylosis, which is bony bridging on the ventral or the internal aspect of the spine. So kissing spine is on the top aspect of the spine, and this is a bony change on the lower aspect of the spine, below the spinal cord, below the intervertebral discs, very deep in the body. Of course, we can have fractures and then congenital malformations. And then in the, just because we're focusing on the back, but to touch on the neck, and then more caudally in the spine, the neck can have arthritis. We can find wobblers, disease, disc lesions, lesions of the intervertebral discs, and of course fractures in the vertebrae of the neck. And then in the sacroiliac and lumbosacral joints, most commonly we'll find arthritis, subluxation, or disc lesions in the lumbosacral space. It's very common. So with kissing spine, we have 4 grades. 1 being mild, 4 being the most severe, 0 being normal. So if you say, anything saying grade 0 means normal. So with grade 1, we have narrowing. So they're not touching, but the space, it should be 5 millimeters or more is normal. And so we just have some narrowing of the space here. And this little bit of brightness of the bone here just shows a little bit of reactivity, but not a significant degree of sclerosis. When we get to grade 2, we have more sclerosis, this brighter spot here and here. There's still a little bit of space, but it's still considered grade 2. We have densification of the margins of the bone touching one another. With grade 3, we have more sclerosis, that brightness to the bone, the densification of the bone, and some remodeling. So this area would be evidence of a grade 3. They're touching, there's remodeling to the bone, and then versus this would be grade 4, more aggressive remodeling, actually lysis of the bone, meaning that the bone's being eaten away a bit, more or less, for lack of a better term. So this darkness to the area is lack of densification of the bone, so that would be evidence of lysis. And then this is just a skeletal example of that degree of severity. So at this point you're thinking, wow, that looks really bad. Kissing spine sounds really, really bad. But don't be worried, because we all, it's a relatively common condition, and we don't hear about horses being retired or going to surgery every day from kissing spine. So, when do we know if it's a big deal? And that is a big topic of conversation in the veterinary community. So this in particular study looked at the frequency of impingement of the dorsal spinous processes, so how common is kissing spine in the radiographs from purchase exams. So it was a retrospective study just looking at 220 warm blood sport horses, looking at their spines and grading them for kissing spine, and then following back up with those owners to say, how's your horse? Did they have back pain? How's everything going? So in that study, 55% of those warm blood sport horses had no impingement, 26% had grade 1, 12% had grade 2, 7% had grade 3 or above. So following up with those buyers revealed that 11.5% of all of those horses had back pain. And the only correlation that they found for statistical significance of that back pain with their radiographic findings was a grade 3 or above. So grade 3 had strong correlation to back pain with a high specificity and low sensitivity. So in the sense of research, that means that horses with back pain tended to have grade 3 or above. But having grade 3 didn't mean the horse was going to have back pain, if that makes sense. And and to me, I was thinking, oh, only 45% of horses having evidence of kissing spine. I feel like I've seen some studies that are a little greater than that. So I referenced back to some notes from my iSelf meetings on the neck and the back and found that some other studies specifically looking at thoroughbreds, because though that breed is, we find more common with kissing spine, 86 to 92% of thoroughbreds have at least grade 1, and 40% of thoroughbreds will have at least one area of grade 3 to 4. So we know that grade 3 or above is more statistically correlated with back pain, and 40% of thoroughbreds are going to have a grade 3 or above. So it's just more likely that our poor thoroughbreds are going to have back pain. Yeah. And so moving on from kissing spine, focusing now on arthritis of the back. So these are the vertebrae of the back. So this image is cut off. So up here, this space, if these continued up here and here, the space in between would be where we diagnose kissing spine. And then the spine lives down in this cage here, and then the intervertebral discs are here. So it's kind of looking like if the horse's back is here, the image is kind of angled this way. So the joints here are the intervertebral joints. They're true synovial joints with a joint capsule and joint fluid within them. So just like coffin joints, hock joints, stifle joints, these are actual joints that are in between each vertebrae along the spine, right and left. So those joints can get arthritis, just like hocks, just like coffin joints. How common is that? How big of a deal is it? Well, this study looked at a post-mortem look at a bunch of spines. They analyzed every single intervertebral space in a bunch of horses post-mortem, graded 0 being normal, 3 for severe degree of arthritis. And they found that every single horse that they looked at had at least one lesion of grade 1. And 91% of horses had at least a grade 2. So if 1 mild, 2 moderate, 3 severe, think about it that way. So at least 91% of horses had at least a grade 2, and that was 100% of older horses had grade 2. I forget the exact age that they qualified an old horse, but I think it was mid-teens. And then 48% of horses had at least a grade 3, so at one location of a severe lesion. And that was 78% of old horses. So about half of their whole study had at least one spot of grade 3 versus almost 80% of their older horses had at least one spot of grade 3. So very common. The most common anatomical areas of this condition would be the low neck. Low neck's a very common spot for arthritis. The caudal thoracic, which is confusing because that's also the most common place for kissing spine, and then the lumbosacral joint. So the reason I bring this up and emphasize this is because this is harder to diagnose, it's harder to image, but it is more common and more clinically relevant than kissing spine. And we find it in the exact same place that kissing spine is happening. So we could take and we know from our previous slides that kissing spine in its mild form is commonly non-clinical. So we could take a picture of a horse's caudal thoracic spine, say, oh, they've got grade 1 kissing spine. Send the horse off to surgery, and the horse has signs of back pain. They've got grade 1 or 2 kissing spine. Okay, send the horse off to surgery for its kissing spine, and then it comes back into work, no better. He could have arthritis in the intervertebral joints, pathology sitting just centimeters deep, but because imaging in this area is just slightly more difficult, and many practitioners are just a little bit less familiar and experienced with imaging in this area, it goes undiagnosed, and the horse either is working up a whole medical process or, unfortunately, sometimes a whole surgical process for the wrong condition. So I highlight this condition because it's underdiagnosed versus kissing spine is overdiagnosed in terms of its clinical relevance. So those are the two conditions I wanted to focus on. There's obviously, several things like I listed a little bit earlier, but kissing spine and arthritis of the spine are going to be the most common things that we're really working on fixing. Treatment options for them: surgery, which is just for kissing spine. We're not going to do surgery on arthritis to the back. We have injections, systemic medications, shockwave therapy, mesotherapy, chiropractic, acupuncture, massage, and many more like electrostim, laser, cryotherapy, magnets, kinesiotaping, all the things. So in terms of surgery, for kissing spine specifically, there's 2 surgical options that we can pursue. The more common surgery that has been sort of tried and true around for a longer period of time is an interspinous ligament desmotomy. So that means going between the vertebrae and so the ligament that lives here between the vertebrae and cutting that and ideally making some space there. So if that ligament is too tight or there's some narrowing to the space there, if we open up the space by cutting the ligament, it'll just relieve a bit of tension. And then that plus rehab exercises can hopefully restore some space to those vertebrae. That's the goal. Versus a cranial wedge ostectomy is a newer procedure, and that means that we're going in and shaving off the bone here to create space more dramatically, I guess. It's a more invasive, more involved procedure. So 2 different studies. The first one looking at the success of the desmotomy procedure said that 90% of horses returned to some level of work following the surgery. 53% of horses returned to their previous level of work. So depends on how you look at it, but I look at that and say, not great. If it's a 50-50 shot for a surgery for my horse, I'd prefer a little bit better odds, but maybe depending on your situation, that's good news. Versus the ostectomy study, a smaller study, 25 cases, but 80% had resolution of clinical signs and returned to full work, with 18% of those horses returning or going back to a higher level of work. So it's easy to look at this and say, oh, the ostectomy is better. Why would anybody do the desmotomy surgery? The problem here, I think, is case selection, because we're going to be, when we have a mild case of kissing spine, we're going to be recommending medical therapies first, right? Nobody wants to put their horse through an invasive, painful, expensive surgery unless they have to. So just by nature of that, we're considering surgery for kissing spine when we have a more advanced case, like a grade 3, grade 4 case. And again, grade 3, grade 4, much more statistically associated with true back pain. So we're more confident that when we take a picture of that back, it's going to be benefited by surgery compared to a grade 1 to 2 where we say, I don't know, that's where blocking comes into play to determine whether or not that horse is going to be benefited by an aggressive treatment to its back. So the problem with only sending horses that are grade 3 to 4 to these surgeries, and not to say that that was the only cases sent to those surgeries, but in general, I think what affects these statistics is that we tend to send horses with more advanced cases to surgery. And as we were discussing with the definitions of grades 1 through 4, by the time we get to grade 3, there isn't much space there. They're not only touching, the spinous processes are kind of melding into one another. So there's no ligament to cut to open up space. So what we really need is the bone to be shaved away. So is it not that the desmotomy surgery is bad? Is it more just that the desmotomy surgery is really meant for a grade 1 to 2 kissing spine where there's still some ligament space there that we can cut and open up and be more likely to gain some space, versus the ostectomy surgery is really meant for horses that are grade 3 to 4 and more bone on bone. So that's my understanding. That's the understanding of other vets that I've spoken to who are doing these surgeries. But I think as the ostectomy surgery becomes more common, we get more cases, better understanding, we might develop some more research, and we might have that information more distinctively versus me just kind of guessing. And then, so beyond surgery, which is just for kissing spine, we can inject the areas, and this can be for kissing spine, for arthritis, and that can be arthritis in the neck, back, lumbosacral, sacroiliac, all of those regions. We can be injecting steroids, PRP, prostride, stem cells, all of those things. So for a kissing spine, we're going to be injecting the interspinous spaces, which is in between these spots. Versus the, for osteoarthritis, we're going to be and sorry, that's going to be usually radiographic guided. You can do it ultrasound guided. It just takes a skilled veterinarian to use ultrasound for the kissing spine injection, ultrasound guided. For the intervertebral joints, we have to use ultrasound guidance. So for a neck, so this is a sideways view of the neck. The intervertebral joints in the neck would be here and here. So this is the ultrasound image of right here with the needle coming in right here and injecting in that space. Versus the sacroiliac joint is right here. So we come from about here and inject down with ultrasound guidance and aim for that spot right there. And then the thoracolumbar intervertebral joints, which are down here compared to this image, we come in with the ultrasound beam, with this spot right here being the joint space and this needle coming in right into that spot. Systemic medications are always going to be a good choice. With significant back pain, NSAIDs or non-steroidal anti-inflammatories like butyramine, Equiox tend to be a little bit less effective just because the pain cycle is so great. Like if you all have ever experienced back pain yourselves as human beings, you know that Advil usually doesn't cut it. It's kind of the same thing for them, but it's always worth a shot. Steroids tend to be a little bit more potent because they're just one step higher on the anti-inflammatory tree compared to NSAIDs. We don't love to jump to those unless we have to, because being one step higher on the anti-inflammatory chain means that there's more side effects that come with that inhibition in the body. But something like prednisolone might be recommended over something like Equiox or Bute for a horse that's really painful. And then there's methocarbamol, or also known as Robaxin, a muscle relaxer, which can just help to reduce the spasms of the muscle that are very common secondarily to chronic back pain. Again, something that we've experienced as human beings if you've had back pain yourself. And then bisphosphonates are bone cell metabolism modifiers, and can be very helpful when we have evidence of bony remodeling with something like kissing spine, but also with osteoarthritis, because there have been plenty of studies to show that bisphosphonates, being os are a more common one, tildren historically common for things like osteoarthritis, any bony type of change that we want to interfere with. Shockwave therapy is a very popular choice. I'm sure a lot of you are familiar with shockwave. I get a lot of questions of what is shockwave, or how does it really work? So without getting into the weeds with how it works, but just to give you, you guys are here to learn a little something, so I thought I'd share that we're working with acoustic pressure waves. So they're sound waves that are characterized by a rapid rise in pressure and then a rapid decline to negative pressure. And that rapid change to the pressure of the tissue creates a pro-inflammatory and catabolic environment. When that pressure wave is applied to a soft tissue structure, say an intrasuspensory ligament or a deep digital flexor tendon, which is what shock waves are historically or originally in horses used for, it will remove some damaged collagen fibers and promote new collagen synthesis rather than scar tissue. So the way that I tend to explain it to clients is that it just makes the tissue excited so that it doesn't get lazy and put down scar tissue. So you want it to be happy and excited, get rid of the bad collagen and put down some healthy new collagen. And for a reason that is not fully understood in its process is that it has this secondary effect of quieting the nerves in the area, deadening the nerve fibers at least temporarily. And so the general belief is that it's that rapid change in pressure that just quiets the nerves. So though that's a secondary effect in the sense of it's not what shockwave therapy has been historically used for, studies have really proven its benefit in conditions like osteoarthritis and any type of bone pain. If we can get access to the bone with enough depth from the probe between the tissue to the bone, then it tends to work very well. So as the efficacy studies that I was looking at is that if we get three successive treatments, there's a statistical correlation with 5 months of benefit. I usually tell clients 3 to 6 months, because you never know how your horse is going to respond. If they're a more painful creature or process, you might get a little bit less than 5 months, but I have plenty of horses that I'm only doing every 6 months or so. And another study, just in terms of the benefit to the horse, which was just a subjective evaluation from the rider. If the horse started off with mild back pain, there was a 100% improvement. If it was more of a moderate to severe degree of back pain, there was a 65% improvement. And finally, exercise modification. For horses, if you're like, okay, my horse has back pain, we're dealing with it, we've got a good saddle fit, we're doing all these treatments with my vet, but what can I do in between to keep my horse strong and healthy and as comfortable as possible? What tends to work for those horses are very individual creatures, so this regimen is not going to work for every individual, everything, but longer walks and then canter before trot. What's funny is that, like, I grew up with a lot of thoroughbreds. I used to just do this, and because I just found that it worked. And then as research comes about, you're like, oh, okay, well that makes sense, because trotting is a very compressive, and you're like heavy in the saddle when you're posting. Versus if you can get up off their backs and let them kind of have a stretchy, long canter before you collect into the canter or ask for a sitting or posting trot, they tend to prefer that. Soft footing is better than hard footing, specifically for the back. And proprioceptive exercises like hills is great. Core training exercises like the baited stretches shown in these, people call them carrot stretches. I hesitate recommending these because I really have to go through how to do them properly, because what a lot of people do is like the bing, bang, where's my treat? And I have to tell people that's not how we stretch our bodies. Like if you're in a yoga class or you're, ideally you stretch after a workout, but if you're one of the people who likes to stretch before, you are holding a position for a few seconds and then letting it go and doing that again. So I can bend my spine by just collapsing over and reaching down to the ground, but I'm not really stretching or helping myself at all. And so what the main benefit of these stretches is really to activate the muscles that bend and stabilize the spine, more so than stretching or promoting a range of motion, because that's just not really the goal. We're not going to achieve that. So what we need to do is ask for them to bend laterally and not reach right to their barrel or right to their shoulder or right to their hip, but stay about 30 centimeters, about a foot away from the side of their body. That engages their core muscles and not just allowing them to collapse and bend to the side. So like this horse in the side here, he's all the way back here, but he's not just touching the hock. Like any horse can itch their butt or their hock. But look at how his abdominals and his gluteals and his hamstrings are all engaged through this stretch. If you just ask this horse to scratch his shoulder or his belly, that wouldn't happen. And then with this stretch, you see how rounded the back is here? That's the goal of this stretch. So I call them stretches, but we're engaging the muscles, we're warming up the joint spaces, either before or after a ride. Other things that some people like to do, sternal pressure. So this is a great thing to open up the spaces here, because whenever there's rounding to the back, those spaces that might be narrowed through the spine are going to open up as the spine rounds downward. So we can do this, or we can put pressure on the sternum and ask that of the horse. A lot of horses don't like that, especially our thoroughbreds with kissing spine, who might also have upset stomachs. So they really don't like that. But you can try one hand here and then one hand on the gluteal here, and that can also allow for a unilateral bend plus a little bit of a flexion through the back, which is nice. But see what works for your horse. It's training. You're not going to get a great bend through the back, right on your first go. It takes some time to teach a horse that you have to wait here for 10 or 15 seconds before you're allowed to have a treat. So that's everything about backs that we're going to talk about in terms of specific conditions and treatments and everything. I just wanted to spend a few minutes talking specifically about chiropractic because it's what I do. So with chiropractic, the goal is identifying what we call intervertebral subluxations or IVC complexes. And that's a lack of movement in a particular joint. So in any joint we have active range of motion. So if my hand is here, this is my active range of motion, and then I have an elastic barrier, so I can physically push my hand down a little bit further, and that's my elastic barrier. But I can still push it a little bit further and get to what we call the anatomical barrier. And that difference is what's called the paraphysiological space. So in chiropractic, we are playing with the paraphysiological space and identifying those intervertebral subluxations and correcting them in the paraphysiological space. We're not only helping the joint, we're helping the nerves, muscles, ligaments, vasculature, and the connective tissue that all serve that region and communicate with that joint. So the clinical goals of this, we're restoring motion to the joint, of course. We're relieving pain and symptoms. We're bringing full function back to the space, promoting healing, and ideally reducing the likelihood, severity, frequency, and all that of recurrences. And if we keep the joint comfortable and moving well, we're going to prevent degeneration in those intervertebral joints and ideally reduce or prevent the likelihood of osteoarthritis that we've already discussed is very common in the back. So in a chiropractic visit, starts off with a history, just discussing, what's going on. I usually watch the horse walk and jog, see how they're placing their limbs, see how they're bending through their barrels. And the trot is ideally to just identify that there's no lameness going on that I should be aware of before I start, manipulating their bodies. And then there's static palpation. Is there anything that is just overtly sensitive to my hand? And then motion palpation, which is playing with that paraphysiological space and seeing if there is a restriction in either flexion or extension in any particular joint space. And then, of course, the adjustment. So when I identify that restriction in a particular joint, giving it an adjustment to ideally restore the motion back to that joint. So just a couple success stories with chiropractic that I've had in the last couple of years. This guy on the left was one, he didn't have any particular lameness or issues, but we started adjusting him, and the owner was like, he's like a 20-year-old who has sticky lead changes. And an old schoolmaster type, like he has automatic, Hunnery right across the diagonal lead changes, and he just has a hard time with them, and it's got to be comfort related, even though he's not lame, right? Because he knows his job, he's a good horse, he's not putting up a fight for no reason. So we started adjusting him, and he would just get his lead changes, like a little angel that he knew he wanted to be. And so much so that it was like we were doing him on a monthly or maybe every 6-week basis, and we started adjusting when his shows were, that he wanted to have really nice fluid changes to be kind of a week or 2 after his adjustment, so that she had some time to school him and then get a pretty colored ribbon. And then the one in the middle was, this is an image that we took at a horse show. I was on the blocks. This is my technician, Casey, interacting with the horse while I was up on my blocks, because this horse, a lot of horses really love the motion palpation of their thoracolumbar spine. Like Casey gets the most nibbles and nuzzling when I'm doing that. Sometimes when we have a painful situation, that's when the horses are going to be the most sensitive or protective of themselves. So sometimes she gets like a little bite here and there, but usually it's nuzzling. So this horse in particular really, really loved to nuzzle, and I just thought it was so cute. I took a video while I was up there, which is not safe, but it was worth it. And jogged my memory as I was going through my phone looking for chiropractic cases. But this one presented acutely at a horse show, not wanting to jump, being very stiff, very good, nice horse, very uncharacteristic behavior. I went out, adjusted the horse. I think I had done it in the past, so I knew that the horse had a neck restriction, and it was something happened in the trailer ride up to the show or something where it was just a brick wall on one side of the horse's neck. And we were able to, because the horse was in regular care, even though he got a tweak, we were able to restore that motion a lot more effectively. And then within the next couple of days, he was winning all of his classes, which was great. And then this image to the left is obviously just something I took from Google. But first adjustment that I did on a horse, I think it was not yesterday, it was on Wednesday. The history was that the horse is just it's very common history, hollow to the left, stiff to the right. I was like, yeah, I can fix that, got it. And the owner was like, no, like I cannot bend him to the right. And I said, well, what do you mean? And she was saying, well, like even when he wants to just look behind him, he always turns to the left. He never turns to the right. And so I was like, okay, I'll go about it a little bit more carefully. So I went through my exam, and she was not exaggerating. This horse could not bend his neck to the right at all. So I was gentle, did what I could, but I told her, this is going to take several adjustments before we see progress. He might have something more serious going on in his neck. So if we're not seeing progress, I should come back out. We should take some x-rays of the neck. There might be some arthritis. We might need to do some joint injections. He might need to go on some systemic medication. And as I was doing, so I had finished my adjustment, and as I was doing that whole spiel about all this other money and diagnostics and invasive procedures that she was going to have to do on her horse, the horse just turned to the right and turned around and looked at his, to the right behind him. And she was like, oh, great, I just said, no, we still have to come back. We still have to make sure he's okay. It's not going to last forever. But yeah, that was a great little success. So I'm really eager to see him in another couple of weeks, and I hope that he's still doing okay. So I just lost my connection, but that was my last slide anyway, so I was just gonna, we just missed a little slide of the group of us to say thank you to everyone for coming.
Oh, thank you.
Are there any questions that I can answer before I think we might take a few minutes, and then Karen will chat? Yeah, go ahead.
Cycling back to what you were saying about the incidence of the kissing spine in thoroughbreds.
Yeah.
On the research, is that primarily off-track thoroughbreds, or is it thoroughbreds across the
board?
board?
Good question. All research is going to be a bunch of off-the-track thoroughbreds or on-the-track thoroughbreds, because that's it is easy to access in terms of population for studies. So I'm not sure that any of them really parse that out. But the thing about kissing spine is it's not really a wear and tear degenerative type of condition. It's more, it's sort of a combination between congenital and degenerative, because it's a combination of genetics and them being used very early on and having short backs and things like that. So, so the nice thing is that when the horse is skeletally mature, if you take it's like say you're doing a pre-purchase on an off-the-track thoroughbred, as long as the horse is skeletally mature, if you take an image of that back, it's going to look like that probably for the rest of the horse's life. Whether or not the degree of pain might develop through the horse's life, that's a different question. So I think the answer to your question is they're probably looking at horses on the track, but it probably doesn't matter.
And then, kind of on that same note, when you're talking about shorter back, has there been any correlation about this in Arabians?
Good question. So, do you know why Arabians have shorter backs? Ooh, that's a good raffle question. That's a really hard raffle question. Karen might be the only one besides the DVMs who know the answer to this question. Yes.
They have one less vertebrae?
Oh my gosh, you knew! Yes, they have one less lumbar. So most Arabians are pretty much the only breed, but they have 5 lumbar vertebrae instead of 6. So rather than thoroughbreds, they're just scrunched together. Like a mini has normal sized teeth, they're just like scrunched together, so they're all a mess. But Arabians have short backs because they just have 1 less vertebrae. Yeah, so they were designed well. Thoroughbreds not designed well. Yeah. Anyone else? That was a good question. Thanks, guys. Yes?
A quick comment about thoroughbreds. My understanding, I could be wrong, but my understanding is that in our desire to gain speed, we bred for longer backs. And that with the longer back came the dorsal spinal impingement.
Because they're swayed, so they're dipping down.
Yeah.
And impinging this way.
Yeah. Yeah, in fact, if you go back in their what do you call it, their genealogic tree, the horse at one time was humpbacked.
Right.
And they discovered speed, they found speed when their backs became concave.
Well, that's an interesting point, because when I think about the sacroiliac joint and the anatomical, this maybe it's a bit of a tangent, but with conformation of a horse's pelvis, Arabians, again, just kind of jogged my memory, Arabians tend to have short croups and an anterior pelvis, and they like, and same thing with like Morgans and any horse that's gonna stand kind of out like this, versus thoroughbreds and any horses that are bred to jump have more of a posterior, like tucked in pelvis, and they are the horses that will tend to have more of a jumper's bump or kyphosis, and they are more like this, so maybe they are bred to be able to bring their hind limbs more forward.
True.
Would you mind if I expounded on this for a minute so I don't
Please.
have to go into this on my talk?
Please.
Great, perfect. So you also have off-the-track thoroughbreds are wearing a half tree. It is not a full supportive tree like we use for our disciplines, but the jockeys use a half tree, which literally the tree ends right behind the stirrup bar on the webbing. So that horse does not have the support throughout its whole back of the rider. So it has an impingement right there, and it doesn't encourage the horse to lift like we're asking them to through the back. So I think that that is one big factor.
So maybe it is. So maybe it is going to be more prevalent in horses that
I
have
do
been
see
on the track.
unraced horses and raced horses, and obviously there's a big genetic factor,
Right.
the breeding for it, but you very rarely see the kissing spine and the same issue on an unraced horse or an
Okay.
untrained horse as
Okay.
you would on a raced thoroughbred.
Yeah, and I thought that the correlation there was more to do with their use at a young age when their dorsal spinous processes were
They
not
give
yet
them no
skeletally
advantage
mature.
in rider support.
But I didn't know about that,
Right.
about the
Yeah.
saddle, which makes a lot of sense.
Yeah.
Yeah.
Thank you.
Awesome. Thank you. This is such great discussion.